dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi avevano dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm an anesthesiologist and I'm proud to be an intensivist. we intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm proud of being an intensivist. We are fighting COVID-19. Together, we are intensive care medicine.
I am an anaesthetist and I'm proud to be an intensivist. We are working together to fight COVID-19. Together, we are intensive care medicine.
I am an intensivist and proud of it. Intensivists with various specialty backgrounds work together as a multidisciplinary team to prevent and treat temporary risk of death due to COVID-19.
My name is Jan de Waele and I'm proud to be a surgery-trained intensivist and work in intensive care. We work together to beat COVID-19. Together, we are intensive care medicine.
Hello. Good afternoon and welcome to today's webinar on prevention, recognition and management of burnout. It is the second webinar on a series of 3 multidisciplinary and multi-professional webinars on human resources and crisis management. Last week, Professor Maurizio Cicconi talked with Professor Stefan Schaller about leadership in crisis management. And today, Professor Elie AZOULAY, who is, among a lot of other things, ESICM's current president-elect and director of the medical intensive care at Hôpital Saint-Louis à Paris, and Dr. Nancy KENTISH-BARNES, who holds a PhD in sociology and works at the Familia study group, also at Hôpital Saint-Louis. They will talk about burnout, the different aspects of burnout with special regards to the COVID-19 pandemic. My name is Laura Borgstedt. I'm from the Next committee, and together with Patricia McCready, I'm very happy to moderate this webinar. We are very happy to take any questions via ESICM TV chat or Facebook or YouTube. Thank you.
Are you starting, Trish, or?
Hi. Was we going to start with Dr. Nancy KENTISH-BARNES giving us some definitions of the with burnout and prevention?
Yes, of course. I think maybe before we actually start talking about burnout, it's important to remind everyone that our job, whatever we do, is a central component to our identity and to our sense of self-worth. So it's not going to come as a surprise that our job has the potential, obviously, to either improve our well-being or, on the other hand, to harm our well-being. So I think that's just an important element to remind everyone. And also in the term burnout, there's a metaphor, and it implies that the person before actually feeling burnt out was burning before, meaning that he or she really liked his job, was fully engaged and committed before he could start to burn out. So I think it's also important to say that engagement and interest in what we do are precursors of burnout. If you're doing something you don't enjoy at all, ever, you probably won't end up by being burnt out, or it will be something different. Elie, do you want to define burnout?
Yeah, thank you, Nancy. And I'm very pleased to be here and to share this webinar with all of you. And thank you, Laura and Trish, for introducing us. Well, I must say that this is one of the very important symptoms that we as ICU leaders, we need to capture when we do rounds, when we speak with nurses and doctors. And most of the time, we are thinking that we are not able to recognize. So we should get trained to know how to recognize these symptoms. On a daily basis, and COVID-19 has been an opportunity to work more together, maybe close to each other, because there were no other places to be. And I think that we have really experienced what is prolonged stress. the first, the second, and now the third wave. And these waves have been they have been the source of many different symptoms. They have been the source of maybe before anything of threat. People has really had the feeling of, they have the feeling of fear, and this fear was for many different reasons. Maybe at the beginning of being sick, or of having the sickness with the family, transmitting the disease to others in the ICU or at home. But then with the successive waves, we have had this prolonged stress, and we need to understand that burnout is not something acute. This is a process that starts long before the first symptoms can be observed. So we cannot explain the burnout by other things that are current in our departments, in our ICUs. We need to explain the burnout looking at around the ICU, at the teams and the history, the climate in every department, in every ICU, to better understand why there are so much people affected by burnout. So burnout is the result of prolonged stress, and it's very different than stress itself. The stress is then when you feel exhausted by an excess of things coming to you. Burnout is exactly the opposite. You feel really empty. You don't feel too exhausted. You are really empty. You have this feeling of being exhausted, but at the same time, you lose the feeling that you can do things correctly. And in your ICUs, if I had to say among the maybe 20 symptoms that are really frequently observed during burnout, I would say that your colleagues that you know, the nurses, the doctors in the ICUs, and many maybe other allied professionals would be cynical. And being cynical is something that you capture very quickly. You see that people are not what they are really on a regular basis. They have changed, and this is something that you need to recognize. Why is it so important to define burnout and to recognize it? It's because we can prevent it. I can't say that the level of evidence is very high, but only by learning from multi-center studies where the proportion of clinicians affected by symptoms of burnout is so different, you can at least understand that according to how ICU is organized, how people work together, how decisions are made for our patients, and maybe how people communicate is really one of the major determinants of burnout. So this ethical climate and this ambience in the ICU is one of the determinants of burnout. Of course, if you have this, people would be affected, but not all of them. And even if you don't have these particular circumstances exposing to burnout, so then you can still have burnout because other people who are at high risk will trigger burnout with much less opportunities. So I think that this is an important webinar because we are in something that affects maybe half of people in our teams that is very severe because it can lead to very severe consequences, something we're going to discuss in the next minutes, but also it's something that we can prevent. And learning from each other, from how we work together, is really an opportunity to prevent and burnout itself. I hope I address in the next minute, we should maybe talk about differential diagnosis. So what can be when you have one of your colleagues not being well, because we ask people, are you well? How do you feel? How are you doing? I think that we have other things, and maybe Trish, you could help us to understand how burnout would be as compared to moral distress, how burnout would be as compared to ICU conflicts, and how burnout could be as compared to other things. Like we know that in a typical ICU, we have up to half the people reporting the perception of inappropriate care. And this is also bringing feelings of burnout without being burnout itself. So maybe we could speak now about the differential diagnosis. Maybe Trish, can you report on moral distress? We don't hear you. I think you're on mute, Trish.
I'm definitely not an expert on that, Elie, but I would probably refer that to Nancy. I think the differences are probably quite complex. I could give you a very loose term on that, but I would refer that one.
Sure, but one of the common things of all these symptoms is that people have, for example, a job to leave an intent to leave the ICU, so they want to change their job, or some are on sick leave, and we need to understand why you have a proportion of clinicians on sick leave. Maybe some we report on back pains, and we know that this is a surrogate symptom of other different ICU disease. And the other thing is that sometimes people are not with all of this, and this is what we call presenteeism, where people are working, they are not in sick leave, they are in the ICU, but you know, they are not really contributing to their task as they normally do. They are the people you know, but they have changed. So maybe Laura, do you have an experience of someone being affected by one of these different symptoms, moral distress or burnout, or maybe other symptoms? Do you have this experience?
Yes, of course. I mean, I'm not as experienced as you all are, but in the last 7 years, of course, I am very familiar to what you just talked about being cynical, about being burning for work, and then all of a sudden, or well, for the outside, all of a sudden losing the energy or losing the fire for it, and also the being on sick leave for weeks and for months, and or even really experienced doctors and really experienced nurses who contributed to the team. They one day or another they just said, okay, no, I'm quitting the job, I'm going somewhere else, I'm going to the industry. And you're taken back and you're like, oh my God, I didn't see this coming, which I think is another big part for this webinar, like prevention and peer support, as you raised already.
Yeah, this is very true. And as you just mentioned, one of the best ways to deal with burnout is to recognize it. And I think that sometimes we are, you know, in a system where we are in the routine, so we are not really captured by the symptoms. And we need to really pay attention to that. So when you round, even as a young an ICU physician, and when you round, when you talk to colleagues, when you share different experiences, it can be a lunch, it can be a coffee, it can be, you know, doing an ICU procedure. You need to really keep an awareness on these different things, because we know that when people are in a sick leave, as you just mentioned, I wouldn't say it's too late. I would say that we should have captured this before. So if we are getting into more details, one of the things that is very striking is that when we look at the determinants of burnout, and as you are part of the next, Laura, ICU experience is one of the major determinants. And as you just mentioned, of course, it can affect people who have 15 years of ICU experience. But those who are more affected are the people who are younger, for many different reasons. I think that there's a kind of access to resilience that is eased with experience. And we also know that when you have more ICU experience, you have been maybe exposed to this prolonged stress, and you have learned how to cope with it with other ways than falling into symptoms of burnout. And the other thing is, when you are in an ICU team since a longer time, so then you would maybe request more social support from your colleagues. You can ask for help, you can ask for maybe understanding better. And if you have a communication gap within the team, you would voice it more easily if you are an experienced nurse or an experienced doctor. So you as the next, I think that there's an initiative from your side maybe, and the next, to maybe recognize and help the young ICU specialists to recognize more easily how we can go to the first step of managing burnout, which is the first R, which is recognize burnout. So we can imagine that people are exposed to prolonged stress, and this stress has to be professional. When we say professional burnout, we are really referring to work conditions that are exposing to burnout, much more than personal situations, because then we are getting into other mental health outcomes that can be more into depression. And in most of the papers, when you want to publish on burnout, you also need to report on depressive symptoms, because burnout is defined as compared to depression. So if you want to report on burnout, as the symptoms might be the same, and sometimes you could also have the same approach to deal with burnout, you should consider also excluding depressive symptoms, which requires that you work in an ICU environment with a psychologist or work doctor or other people more experienced to manage that. The good thing is that, yes, please, Nancy?
No, I just wanted to, as you're talking about a professional environment and one's personal life, and burnout is definitely, as you say, related to your work environment, but also some research has shown, especially maybe in sociology, that role conflicts experienced in the work environment are a trigger for burnout, but also when there's an absence of balance between work and personal life, it can also increase the risk of burnout. So if you have, let's say, a young doctor who's having to work very long hours and doing a lot of night shifts, there might be a role conflict for him or her because he won't be at home for important life events for the children or any other important personal events. So I think it's definitely focused on the work environment, but it's also to do with a balance between life and personal life, and professional life. I don't know if you agree, Elie?
Yeah, I really agree. And I think that what you just mentioned is very important. I think when we analyze a situation of burnout, we need to make the difference between what is related to work, what is related to lifestyle that can also expose people to burnout, and what is related to personality. And very recently with Nancy, we did a paper on the COVID-19 experience for healthcare providers, where we could correlate the type of personality and the elements of personality with risk factors for burnout. But this has been already mentioned in the sociology and the psychology literature, where we know that the people who are more exposed to burnout are those people who are perfectionists. Look, Laura, I'm sure you're going to recognize every ICU specialist. Perfectionist who need to control the situation, because you really need to be sure that you are getting into the right side for the patients, with difficulties to delegate. And we know that this is also something that we can find in ICU specialists with a certain type of personality. So if we want to have a global view on burnout, we need to work with work doctors as well as with psychologists. In the literature, other risk factors for burnout are related to work. And I think that hectic work environment is one of the major determinants of burnout. And we know that only by reorganizing the ICU work and the way you are respecting the shifts, you are working together, that you can maybe sometime accept that someone can be delayed because they have a family problem or they have any organizational problem. So the work environment and the way we organize the work is also a risk factor for burnout. People complain when they have symptoms of burnout of not being able to control, to be recognized. And I think it's important to have this kind of recognition with the work we do. They complain about excessive demand that are, always the same thing. So you're asking someone to always do the same thing. And this repetitive kind of work is also exposing to burnout. And of course, as just Nancy mentioned, the balance between the work environment and the personal lifestyle also are risk factors for burnout. But again, the important thing is that people are usually not in an acute situation. When you talk to people, they say, well, 3 months ago, I already mentioned that these situations are very hard for me. And then people are going to organize a resistance. They're going to really cope with the situations until they are overwhelmed and they are into sick leave. So I think that preventing burnout by capturing the different symptoms, by understanding the feelings of burnout is important. Nancy, you might have had semi-structured interviews like you do with people affected by burnout. Is this something you can maybe report and tell us more about it?
Yes, definitely. Well, recently in the research we did during the pandemic on nurses and physicians' experience, they did talk about, I don't know if they were burnt out or not, because I didn't actually use the different tools that we have to measure burnout, but definitely I could feel that they were somewhere along that line, because they did mention a lot, well, the fear that they were, the sort of ambiance that they were working in, the fear of being infected and infecting their family. Also a lot of uncertainty, not knowing really, not having a sense of control. And I think that's a difficult aspect of work in the ICU, and specifically during the pandemic. And also a very strong sense of monotony. All the patients were the same. It was always the same thing. And they really did feel that it was dehumanizing. And they really regretted that in the interviews that I did, because they felt that there was a role conflict there. They weren't actually doing their job as they would like to do it, like to get to know the patient, get to know the families, and they couldn't do that. So that frustration, I think, and that role conflict there was an important trigger for burnout, maybe during the successive waves of the pandemic. And also, but we just mentioned that, losing the balance because between life at work and life at home, because everyone was, a lot of the clinicians were working very long hours, much more than they already work long hours, but much more than they're used to. So that was also another problem for them, which did come out in the interviews, and feeling guilty also about not being able to look after their family and be with their family and just spend time outside the work environment.
So those things you mentioned from the semi-structured interviews, Nancy, you did, they fall into the six modifiable factors, which independently associated with the presence of symptoms of mental health disorders, which you describe in your paper about the ESICM survey on burnout. And we have a question from the chat, which I think relates to what we already discussed. And it says, how do we hold organizations responsible for staff burnout? And should they be? Because they are modifiable factors.
Well, that's a very good question, I must say. There are many different ways to cope with burnout. And I think that people in the departments need to be aware of how to recognize burnout. And I think that burnout is considered to move like an epidemic. So people can not only be in burnout, but also contaminate colleagues by, having this constant feeling of frustration. So people say they are overwhelmed. I think this is a constant symptom, but they will never come to you to say, I have these symptoms. They will complain on their side. If someone is stressed, if someone is depressed, if someone has, a problem with a decision that has been made in the ICU, they would maybe meet with the team or come to the ICU director, the head nurse, to discuss the problem and maybe to find a solution. When there are symptoms of burnout, people don't complain about it. People come to you for other reasons, or maybe they come to you to say, I'm going to quit because I'm not able to meet the constant demand. You are asking too much from me. I became vulnerable, and I have to stop my work because otherwise I'm going to make mistakes. And this is why people, usually this is the reason why people are going to seek leave, is that they say, if I stay, I'm going to do mistakes. And I think it is important to recognize that, not only to give value to these words, but also to reassure the colleagues and speak to them, to tell them that you are actually aware that they are doing their best, etc. But you can also offer your help, because people usually complain of helpless. They say they are helpless, they are hopeless. So you can help them understand that they are actually doing what they have to do, but it's only that they have the feeling that they cannot meet our expectations. So I think that only recognizing the situation will be a big help. So the question was about ICU organization. Let's look at the main determinants of burnout. So it's related to hectic work, it's related to life balance and to personality. So I think that sometimes we also need to understand that our colleagues need to have time without a very heavy ICU environment. So this is why sometimes in the same department you can have a step down, you can have a post-ICU facility, you can have an ICU, very heavy ICU beds, and you can have also sometimes other units where you do other things like procedures or like maybe more monitoring for post-operative patients. So I think that sometimes when you recognize that one of your colleagues is at risk for burnout or have already symptoms of burnout, you need to decrease the pressure by having this person, of course, sometimes on holidays, you should say, you should make a break for 2 weeks and may go and see your parents, and may sometime you should cook with your kids, or you should maybe have basically vacation. And sometimes people can, because they say, well, my kids will be on holiday in 2 weeks. I have to work for these 2 weeks so that I will be in holiday. They don't even imagine that they are going to be in sick leave. So for those people, you could take them to the step down, you could take them to the monitoring unit, you could take them to the post-operative unit, so that they will do something else than having, the very complex decisions to make, and it's something that is going to be easier for them. Sometimes you could also ask people to stop doing nights. And this is a very good way to decrease the pressure and to decrease the feeling of for those people who are reporting they are overwhelmed. You should say, for example, so stop doing nights for the next 2 weeks and go back to a normal life, have a good sleep, and maybe you should have 1 or 2 days off after the weekend, so that people will be able to consider that they are going to have some rest. And the last thing is about complex medical decisions, because sometimes we are at the border with moral distress, burnout, and ICU conflicts. And we know that sometimes one particular decision, one particular patient is going to trigger a situation of conflict that is going to be associated with burnout. And in many studies, the feeling of burnout and the symptoms of burnout are also associated with the ICU conflicts. So we need to understand that when you have an ICU conflict, you are exposed to burnout. So we need to have people who are at risk or who already have symptoms of burnout. We need to understand that these people should be in another environment. Maybe they should not be in sick leave immediately, but we should try to have another environment for them and to take them to another part of our departments where they can do other things. And the last thing is to increase communication. I think that the ICU communication and communication gaps not only expose people to have moral distress, but also to have these feelings of burnout, these symptoms of burnout. And I think that increasing communication has been the study of a trial, a pre-post trial, where burnout was measured, and the only intervention they made in the after period was to intensify communication between nurses and physicians. And this was successfully associated with a reduction of symptoms of burnout. So we, as ICU leaders, we have many different options to improve the way our colleagues are working, and maybe sometimes also to prevent burnout or to alleviate these very hard symptoms of burnout that up to 50% of the ICU colleagues have reported during the COVID-19 experience.
I'd like to say too, I agree obviously with everything that Elie has just said, and he's mentioned a lot of strategies where the leader will go to the clinician who seems to be suffering and will propose a step down or to stop night shifts, etc. I also think, and Elie has just said so, that the responsibility of the leaders is to create a healthy work environment, and communication is definitely part of that healthy work environment. So definitely, I think institutions, should really promote communication training, because we know that it can help, and team building, which is extremely important for burnout and for providing support between peers. So I think that's another important aspect of preventing burnout on an institutional level. And also, I think it's good to obviously observe colleagues and to try and help them when you see that they're suffering, but it's also important to promote autonomy and self-control. So giving clinicians more flexibility, maybe to deal with their scheduling, how many night shifts they're going to do, to give them more control, I think, is also an important way of helping them be proactive, because what you want is people to be proactive and to, in their, A, recognizing that they're suffering, and B, what they can do to help themselves, and not to let them be too passive, because that is also a vicious circle. So I think it's a combination of leaders helping clinicians who are suffering, and clinicians being aware of the situation, and that they're given a bit more autonomy to in how they deal with situations when it's possible, obviously.
Well, comes to my mind when we talk about autonomy and changing the environment for clinicians at risk, I'd say. And with clinicians, I mean everyone working at the ICU, not doctors especially, but everyone. How can we do it without making them feel like a failure, or like they are being punished because they are now transferred to the PACU or somewhere else where it's supposed to be less stressful? How can we do this?
Well, Laura, this is a very good point. I think you really raised something that is the reality. So this is a very good point. I think that actually, when you are suggesting people to step down and to have maybe a calmer time for 2 weeks, they're actually very thankful. They're not frustrated. Frustration comes from the feeling of being overwhelmed, much more than from something that is imposed to you. And usually people actually request for help. So they would accept any guidance. Of course, sometimes we also need to work with our psychologists. We've experienced people in the team, in nurses and doctors, who are really with experience and can help to address the issue. But overall, people accept your suggestions and they follow your advice. And this is very important, very, very important.
Can you suggest any strategies and ways to increase joy at work, things which we can do as an approach to stop sort of more burnout and other wellness issues?
I think that's a really important question, because you know that burnout is contagious. It was shown in an interesting paper, actually. The more you interact with people who are complaining and unhappy, the higher the risk that you'll develop burnout. So I think it goes back also to team building and support and joy within a team, sharing obviously bad times and stressful times, and debriefing those stressful times creates more trust, and sharing obviously good times. And I think informal moments in the ICU are really important. The parties that you can have now and again, those shared experiences, which also bring a lot of joy, are important. They bring memories that then you can refer to afterwards. So I think it's part of the team building to create a positive atmosphere too.
And Trish, I think that not every ICU team should have the same intervention to decrease burnout. For example, we are not starting from the same points. Sometimes you would be very surprised. You come to my ICU, I'm going to yours. You would be surprised by the proportion of people not saying hello, for example. So I think that we need to understand better what's the starting point. What are the relationships between people? How many new people are in the ICU as compared to people working here since 15 years? And I think that you would have more burnout if you have more new people in your ICU. And the paper from the group of Barariku in Switzerland, in Geneva, reported that if you have more men in your department, you would have more burnout. And I found it very interesting because, you know, I think that there is a kind of bias based on the self-report of symptoms. And I think that men would be different than women. But the gender ratio in an ICU is also something very interesting, because I think that the behaviors are not the same. So I think that every ICU would have different interventions to improve the way you say joy, which is a wonderful word when we speak of work. But this is it. And I think that mortality rate in your ICU would be one of the major determinants of burnout. I'm sure that those ICUs dealing with very sick patients with high mortality rates, a lot of cardiac arrest, a lot of immunocompromised patients, and maybe less post-op patients would be situations where there is more burnout, because people work with a kind of tension. And I have plenty of colleagues reporting on how difficult it was to deal with prolonged ECMO in the COVID-19 pandemic, where you are doing care, but you know that people may not be responsive to the care you provide, and that you are maybe in a kind of inappropriate care, and you should sometimes consider doing differently. So I would say that what you mentioned is very important, and I would suggest that different strategies would be decided for different ICUs. But there is one common thing, is that all of us and all the people who are here listening to us need to know how to recognize symptoms of burnout. And this is very important. And it's sometimes very difficult. And I think that, Laura, there is a large space for the next to do an observational studies in our ICUs. Because in our ICUs, it's typical. We have nurses who are here since weeks and nurses who are here since years. We have the residents, the interns, the fellows, the attendings, the academic people, and we know that all of those people are not exposed the same way to burnout, and they're not responsive the same to any intervention. For example, I found it very difficult that people would complain for physical symptoms. And sometimes people are painful, sometimes they have gastrointestinal symptoms, and it's only burnout. And we know that quite well, but we need, of course, all the time to recognize that. And I think that emotional depletion can sometimes be really presented like a physical disease. And this is very, very important. Depersonalization, which is that you don't recognize your colleague, who became cynical, who became very negative about everything, anything you would suggest. And look, Trish, if you want to do something to improve and to increase joy in your ICU, anything that is, good intention, people would say, oh, there is no reason to do that. It's not going to work. People are negative. People are detached. They are losing motivation. And they're also a little bit dehumanized. And as just Nancy mentioned, I think that we should not consider that people are like that. We know them since a while, and we know that they have changed. And this change needs to alert you and to consider that when they feel they're incompetent, when they say that they should stop working because they're going to do mistakes, you need to recognize that your colleagues have changed. And I think that this is common in all of our ICUs.
Should we, this is a question, but do you think, Elie, that leaders, whether nurse leaders and doctor leaders in the ICU, should be trained to recognize burnout signals?
Yeah, I absolutely believe that this is very important. I think that we spend a lot of time in management of different things, but we also know that something that is so severe, people with burnout, they have, they have addictions, they have, they have food behaviors that are very, very different. They can be sometimes depressed. All the night they think on the work, and all the day they are with sleepiness. So we need to recognize that. So yes, I think that we should be trained not only to recognize, but also to have management strategies that are sparing our colleagues to be extracted from the work environment. But sometimes I would even say that even the step down would be very difficult, and some people should be staying in doing research or preparing. You could say to someone, look, you look very tired and you look exhausted. So in 2 weeks we have this unit staff level meeting. So we are going to meet all of us. Maybe you should do something, or hospital-acquired pneumonia, or catheter-related infection, or you should prepare the course and maybe work to prepare this. So people will get extracted, but will have a mission, so they will not feel frustrated of having nothing to do. But yes, Nancy, the answer to your question is not only yes, we should be trained to that, but I think we should be trained by professionals who are working on preventing burnout. Work doctors that are very good at it, psychologists, and trained nurses and doctors who have an interest for that.
Do you think so it could be something that goes back to physician and nurse training from the start? It could be incorporated into it, but also, do you think there could be some sort of psychometric testing which would say whether an individual is made or is good to be in a highly stressful environment, or whether it would have a long-term detrimental effect on them?
Well, what you mentioned, Trish, has been really worked on in the psychology literature. Should we, for example, when you hire a pilot, you are also making everything that he doesn't wear any glasses, so you have criteria. So some people have said that we should maybe screen clinicians for their ability to work in an ICU as compared to other wards. We know, for example, that emergency department, that ICUs, that oncology and hematology have 50% of clinicians reporting burnout. So we know that maybe some clinicians, based on what we say, the lifestyle balance, the personality, etc., should be excluded for that. But I don't think I'm pro of that. I understand that we discuss this because we know that a nurse or a doctor with burnout would have less satisfied patients, less satisfied family members, and there are even work that have suggested, not proven, but have suggested that there are more medical errors when you have a burnout. And recently, this very nice paper done in US hospitals showing that the nurse-to-patient ratio, for example, is associated with burnout and can also translate into mortality differences. So I can understand what you say, and that would be our responsibility sometime to screen people for their ability to work in the ICU. Should we go psychometric for that? I think that this is more a global discussion that involves other considerations, some of them being ethical considerations on how we should work with people and how we should give a chance to people. I would say it differently. I would hire these people, but make my best that my ICU environment is better, that the ethical climate is better. And when you look at the works and the very important studies published by Dominique Benoit in Ghent University Hospitals in Belgium, and his works that have worked first on the perception of inappropriate care, but also they went to disappropriate care, excessive care. So all these works have actually brought a high level of evidence that there is a direct relationship on how you work and how you do. And I think that we should more work on improving the work environment rather than depriving people to do our wonderful specialty and for the opportunity to be an ICU specialist as a nurse or as a doctor. Laura, I'm sure you agree with me.
Yes, definitely. And the next question falls into this, relates to what you just said, because someone asks if there was a scale or score which you two would recommend to apply to a multidisciplinary team, or if there was a score that is able to capture the frequency of burnout in a team, or they wrote capture. I'd say maybe the prevalence.
But there's a wonderful woman working in the US, and if you write to her, she will reply immediately. She's very, very nice and very, very smart. Her name is Catherine Maslash, and she reported something like 50, maybe 18 years ago, the MBI, the Maslash Burnout Inventory. And we are not psychologists, we are not psychiatrists, and we are not work doctors. So we need to learn based on what we can understand. And the metrics for us, and with Nancy, we always have this discussion. We are not able to make a diagnosis of post-traumatic stress disorder, depression, of anxiety. So we are used to use scales that report on how much you have symptoms of that. So for burnout, symptoms of burnout, the MBI, the Maslash Burnout Inventory, has the strength of being very easy to complete. It's 22 items, and it has also the strength of reporting the 3 domains, which is the emotional exhaustion, the personalization, and the loss of accomplishment at work. And I think that it's very easy to measure, it's very easy to complete, it's reported in 3 different domains, and you are able to understand how you're going to deal with burnout in your ICU. The other good thing for the MBI, it is responsive to an intervention. If you do, for example, something in your ICU, like involving nurses in the round, which is very important, or maybe sometimes assessing patients' symptoms with the nurses, doctor and nurses will go to the bedside and assess patient symptoms. We know that if you do that before and after the intervention, the MBI would be responsive to the intervention. So the answer is yes, there's a metric. The one that is usually used in the critical care setting, in the emergency department, or in the hospitals is the MBI, and it's very reliable. It describes the 3 domains, and it's amenable to changes. So I would recommend this metric as compared to others.
So we talked about burnout and risk factors or predictors of burnout, and there are the 12 stages of burnout, which start with excessive drive or ambition for work and end with a mental or physical exhaustion or collapse. So what would you say in your expertise? Do the steps build up, or do they go chronologically, or is it just one person starts here and then jumps to this step and then goes back to this step? And where can we intervene, or where can the leader or the chief of the department intervene? What would you suggest?
Well, as you just said, by asking the question, it's a conceptual model. And I think that the conceptual model only reports on what should be in our mind to recognize that people are at risk of developing severe symptoms of burnout, something we want to prevent. So this is why conceptual models bring a kind of simplicity to understand what we are dealing with. And this is the same for conflicts, this is the same for moral distress, or for the perception of inappropriate care. But obviously, according to who we are, we would be very much sensitive to any frustration if we were, look, for example, if you have a new nurse in your department, and the new nurse has been working for 10 years in oncology, she cannot be considered as a new nurse. She's new in the ICU, and the ICU environment will add to 10 years of oncology. So she or he will be at risk of burnout. But it's very different when you have someone being, new in the profession as a new nurse, a young nurse, or a junior doctor. So these people are really at risk for burnout because they don't know the codes of our very, complex environment. The ICU is a complex environment. There are many people. Patients are sleeping, so you cannot have a normal patient-physician or patient-nurse relationship. You have the family members, and even if as experienced ICU physician, we love to speak to them and we need them to have a normal relationship, sometimes we are, anxious about how we are going to report bad news, or sometimes uncertainty. Managing uncertainty is very difficult for us as clinicians, so it's very difficult for the family members too, and we are having distress. So I would say that when we analyze a system and when we analyze a situation, we not only need to capture what is in the ICU, we need to understand who are the people, but also what is their professional trajectory. Because one of the paradoxes is that people at risk for burnout would run for departments where they would capture the burnout. So sometimes they are looking for it. And of course, it's unconscious, but we need to understand where they were before, if there were any work problem before, and how they cope with it. So when you have a new nurse in the ICU, you have the feeling that the person is, either at risk or with so much experience that she or he is not at risk. But the reality is that we need to understand what's the trajectory before that and who are the people as a whole. So I think that the conceptual models are interesting, but they are not bringing a sense of reality. They are just conceptual.
And I think it's also, it all starts a lot with expectations. What are your role expectations in the ICU? And some people have very high expectations. So I think it's also the role of colleagues and leaders to discuss these expectations with maybe their younger colleagues to see if their expectations are adapted and whether maybe they can renegotiate those expectations to avoid role conflict and then burnout. So within that conceptual model, I think it's each person is different, as each person has different expectations, and how they're going to interact with their colleagues is obviously going to be different. But I think that another role for colleagues and leaders is definitely to systematically, I would say, discuss expectations when a new nurse or a new doctor starts in the ICU.
Definitely, and I think teams is definitely, I think teamwork and being a member of a team. Bear with me.
Trish, we don't hear you.
Sorry, they had a bit of a flood. They're having a bit of a problem on the HDUs. Sorry. No, I was saying I think that teamwork, and I think that's all part of it, and being part of a team and having a team to support one another during difficult times has made a lot of difference for my team and where we've been here. I don't know if there's any thoughts on that with yourself, Elie, or Nancy. I don't know.
Well, definitely that came out in our qualitative interviews, that the importance of solidarity and teamwork, it was absolutely major for helping clinicians just cope with the everyday situation. And I think maybe what wasn't done so much after the first and second wave of the pandemic was debriefing sessions, because I think when you've been through a lot of stress, if you don't debrief those situations, then people live on with that stress that they experienced, with the unhappy memories, etc. And when you debrief, you encourage good communication, sharing experiences, and trust also. So definitely, I think team solidarity and debriefing actually go together, especially after highly stressful situations like the successive waves of the pandemic.
Yeah, I think what we've been very lucky. I mean, all the way through, we've had psychologists support. They've been around at the beginning and end of shifts to sort of to speak with us, to do any debrief. Also, they're doing support groups. We've had well-being centres. We had free dinner and free lunch during the sort of pandemic, during the surge periods, and we all ate in the sort of same areas. I think all those things were incredibly helpful. Is there anything that you could think that you could add to that? I mean, is there anything else more that you can do? I mean, I think it's a continual thing with us and our teams. We do have very good sort of communications, and it's a sort of 24 hours a day, sort of a lot of WhatsApp, and there's a lot of support that goes on.
I think that you are raising a very important point, Trish. The question is also that we don't have the culture. Maybe it's related to ICU specialty, but I don't think so, because we have been working in so different environments, and we don't have the reflex to congratulate people. I think we should do that more. We should give value to what people say, to what they do. And sometimes, we consider normal that people do wonderful things. And the COVID-19 has been this kind of situations where, at a certain time you observe around you and you say, wow, all those people are wonderful. They are doing something amazing. And I really feel happy and proud of working with such people. And I think that this has been one of the click of the COVID-19 pandemic, is that we have been thinking differently. So yes, we need to bring joy. We need to be, I like the word solidarity, because this is really something that misses sometimes, because we are all very busy. We are all running in all the directions. So solidarity is something that is really preventing burnout. But we also need to give value to what people do, to what they say, and to their acts. And Nancy, you said we should be trained to recognize and manage burnout. We should also be trained to work with a group. And this is not something that is so natural. We need to learn that. Some people have this as a nature, but some others are just unable to say and to voice what they feel. And I think that would bring a very important help to what we do.
So speaking of teams and role expectations and family and fear, what do you think, or what were your experiences concerning relatives? Because relatives are a crucial part of the ICU team. And now they weren't allowed to go to the ward, they weren't allowed to visit the patients, they weren't, they only had information via phone. And so I think this put relatives, obviously, but also the hospital staff caring for the patient, and the patient, if he or she was conscious, under a lot of pressure and unexpected pressure, because we've all never been in this situation before. So what are your experiences with this? How did you deal? What were your experiences?
So Laura, my first answer is that when a system suggests regression, you should answer by transgression. And I think that they recommended that we deprive family members of visiting the patient in the ICU. So the first thing we did is that we transgressed that. So we never deprive family members to come to the ICUs. Of course, during the pandemic, we were not having, waiting rooms, because this is typically the place where you get a cluster of COVID-19. So we didn't want that. So we were quite organized when people were sick themselves with symptoms, because, the patient and the family members were living together. So when one was sick, the other one had symptoms too. So we were making everything to avoid having sick people coming and visiting in the ICU. But otherwise, we transgressed completely what was recommended. So transgression, when sometimes you are asked to do something that is not in your personal philosophy, you should consider transgressing. And I think that this is also preventing burnout. But you mentioned something, and we had the discussion with Nancy at many times. I think that family members could also prevent clinicians' burnout. We know that, for example, when you add pressure to a nurse, when you change the ratio, you add one patient per nurse, you are going to increase nurse distress, you are going to increase nurse burnout, you are going to increase patient length of stay. So by trying to make economics here, you're going to lose money there, but also you're going to increase mortality, and you are also having, in a few months, your nurses are going to leave the ICU. So I think that family members can be a safeguard for that. Family members know that the clinicians need to be okay. They know that the clinicians need to work in a healthy work environment, in a good ethical climate, and I think that they can contribute to that. They contribute to that by bringing us the opportunity to have normal relationship with our patients. They contribute to that by letting us know who are the patients as people, as persons, so that we can really care for them as they were willing to. So we can respect patients' preferences and values. And the last thing is when we make decisions. Making decisions on our own is really insane and safe. So I think that the family members are a very important component of the ICU world. They are not visitors. They are part of us. They are part of the team. Of course, when they can, it's not something that we need to impose to people, but we need to let them live in our environment and take their place. So you said having the family members out of the ICUs was a situation where we were at risk of burnout, and this is very true. And one of the reasons why we were not feeling very well was because family members were not there. But again, when you compare studies that we did during the pandemic or before the pandemic, the proportion of ICU clinicians with burnout is exactly the same. It's 50%. It shows one thing very important, is that burnout is not something acute, it's a process. So I would be interested to see how people will be and will do in 2 years. I would be interested to see how people are doing 6 months after the real end that we hope for of the pandemic. So we know that now we are capturing symptoms. Some are doing better, some are worsening, etc. But if we really want to know what are the sequels of the pandemic, we need to wait for the end of the pandemic and take some time to see what happens in people's mind. And I would be interested to see how people are doing a little bit after the pandemic, and we are not there yet.
What we did show, though, Elie, with the first survey that we did was that having restricted family visits was associated with an increased risk of anxiety and depression in clinicians. So I think that was quite an interesting result. And it actually, it's what we found when we did our qualitative research, is that obviously families, because we also interviewed families, suffered terribly from not being able to see the patient and to not being able to meet the team. But the team really suffered, and we were actually quite surprised, to tell you the truth, at how much they suffered from the absence of family members, with Elie said so, not being able to know who the patient is in the bed. And also, I remember a doctor saying, well, my impression is this, that I'm creating so many complicated griefs. And that's a burden. It's really hard to live with when you feel that you're obliged basically to do your work with less quality. I think that is a real trigger for burnout or for incredible stress anyway. So I think the pandemic was interesting in that it really did show that we can't work without the families in the ICU, that it's not good, obviously, for the patients and for the families, but it's not good either for the clinicians.
So have you heard about the 3 R's approach for burnout?
No, Elie, tell us about the 3 R's.
The first one is recognize, so we spoke about it. The second one is as much as you can reverse, so do everything you can do to avoid having the sick leave, to avoid being at the end of the process that takes burnout out of the system. And the third thing is resilience. Help people build resilience. And I think that everyone can recover. So it was a very nice discussion we had with a work doctor here in my hospital, whether people who suffered burnout could come back to the place where they worked by having a safer work environment as compared to excluding them to this work environment and taking them to safest places. And well, I don't have the answer because specialists are struggling on whether we should take people to the places where they develop burnout. But I think that you can develop resilience even in the places where you work and even in the ICUs. So sometimes everything is in the side of the personality and the person. And I think that in this case, we need to work with work doctors and psychologists maybe to think on what's the best for the clinician. And other times, I think that we can rebuild the ICU environment to make it safer and healthier for the clinicians. So my personal feeling is that a clinician can come back to where he or she was working without developing again burnout. So building resilience is something that is very interesting. Maybe Nancy, can you tell us more about resilience and how you think that is it something real? Is it only a process, a mental process, or is it something really that we can help people develop and we can assist people to take them to their process of resilience?
Well, obviously it's an individual process, but it's also, I would say, a collective process. And I think all the different interventional studies to try to reduce burnout or job strain did show that if you help, and I'm thinking of the study that came from France that was published in 2018, if you help nurses improve their ability to cope with stress, to face stress, then it's associated with a decreased risk of burnout or of job strain, actually, in that study, I think. So it's something that you must learn how to do. I think it's probably quite just difficult to think, oh, I must be or learn how to be resilient. But I think, well, by sharing and getting correct support, and support can be just with your loved ones, because just expressing how you're feeling can alleviate the burden, but also getting professional support if needed. So I think one has to learn on our own and also with others how to be resilient. And I definitely think it's something that one can learn, and it has been tested in different studies, and it does prove to be quite effective.
I really agree. I think that to help people build their resilience, we can target organization, we can target individuals, and we can target, the group of individuals. But overall, we have a role for that. Of course, not us as a ICU specialist, but we can learn from many different training skills programs. But also, we can be helped by work specialists and psychologists. Sorry, Trish, you were saying something?
No, I was going to say, I think some of it comes down to life experience. And I think the experience you have in life, and I suppose with that, you've got to say a little bit, it has to come to age, which is something we don't like to say, ageism and all those sort of things, but also that, that comes with coping strategies too. And I suppose as somebody who's slightly older with life experience and coping strategies, it's looking out for the other members of the team and recognizing in them when they're showing signs of stress, when they're looking like they're going to possibly burn out, and trying to sort of catch up with them, pick up with them, sort of try and, sort of suggest, sort of talking to their teams, possibly to the psychologists. And I think it's being aware of it and looking out for it. And I think a lot of it is down to sort of peer-to-peer support, and a lot of it is teamwork.
And I also think or besides awareness and experience with it, it's also the structure, like implementing structures for debriefing or making it available to everyone very easily is a very important part. And also someone from the audience said that they were introduced to the concept of moral injury very early in the surge of the COVID-19 pandemic, and it helped them very much. So just knowing about it and just being in an environment open to the concept of moral distress or moral injury or burnout or so on and so on is very important.
I agree with you, and I think that it would be bad to put all the responsibility on the individual, that he or she should learn how to cope with stress. It's his or her responsibility. I think it's a shared responsibility with the institution and obviously the ICU team. And I think one mustn't forget that, because it's a little bit too easy sometimes to say, oh, well, he's just got to deal with it and he can find his or her own solution. But I think it actually is the team's responsibility. And it goes back to one of the first questions I think that you had was how, I can't remember what the first question was, but is it the team's responsibility if a person develops burnout?
Should the organizations be held responsible?
That's right, yeah.
I think it could, to look at it in a different way, maybe. I think this is one of the few positives to come out of the pandemic is, that we are now sort of more aware of our sort of the emotional well-being of the team and of the staff that are working in ITU. Before, I think, things were changing, but there was an element of you just get on with it and you just do it. And that was part of it. But now as the pandemic heightened amounts of stress within the sort of individuals working in critical care, I think it's now recognised, talked about, and we are starting to deal with it and deal with it in a positive way. But in a sense, I think, these issues are all things that could have been sort of started pre-pandemic, quite, years before. When things like pandemics and crisis hit, we're in a really good position, and we can all the different strategies and are in place already. So if for stress and burnout.
Yeah. Well, I really share what you just said, and I think that if we move now to how we can deal with an obvious case of burnout, and how we could manage a team that is at high risk of burnout. I was quite surprised to see that there were very small literature about it. And I think that we as ESICM, we should share our common experience. And I think that the next who are by definition really exposed to seeing the ICU for the first years, you should help us actually to, many parents teach a lot to their kids, but many kids teach a lot to their parents. So we can learn from you. We can learn from you because you are a new generation where you can voice things much easier than easily as compared to us. We are, in a kind of language barriers and communication gaps that you don't have yourself as a new generation. So we can learn from each other. I was very interested to see that in 2015, a paper has been published and was quite positive. It's an intervention, so it's a randomized control trial, and it was a crossover design, and it was about mindfulness. So it was mindfulness, yoga, and music for healthcare providers in the ICUs, and it was positive. So I think that if we care for people, if we create another work environment, and look, we are all smiling, but it should be a smile. I think that we should start doing things in our ICUs. And Nancy, for example, is now working on virtual reality for family members. But we could imagine that this could apply to family members. They could to healthcare providers, where they could relax. And some did that during the COVID-19 pandemics. Were having a kind of nap, 30-minute nap during a 12-hour shift, or maybe a kind of a relaxing moment in a calm place. And I think that all of these things should be created in our ICUs. And without considering that it's a failure or a weakness, we should just be aware that we are having a very difficult work, and we need to also consider that some in our teams are at risk of developing burnout, and we need to help them. And helping them by creating a safe or a relaxed or anything in the environment could be a very good thing for the good of many of the clinicians, but also it will translate into better care for the patients and for family members. So we should see it as a whole. So one trial has demonstrated benefits from mindfulness. The other one has demonstrated benefits from intensifying communication. And we know that clinicians, there's the communication gap in the ICU is something that is much reported, and clinicians want that we intensify communication. We learn how we can communicate better and more. So we should take lesson from that and translate it into actions at the bedside.
Definitely. I think there's lots of interventions. I think that there's all things that help, and it's all the slightly sort of fluffy areas. I think music in ICU can make a lot of difference. I know in our trust we have live music, and it's very uplifting, not only for patients, relatives, but also for staff, I believe. I think animal therapy, we have the pat dogs coming in the UK, and that always brings a big smile. I think if we have teams that definitely have food, eat together, that's a great thing for sort of building up teams and teamwork. And slightly is gardens. ITU gardens is something now is talking about in the UK. A nice environment for the patients to go, for staff to go, for relatives to sort of meet up with the patients that are in ITU. So I think there are a lot of initiatives, and I think it's the things that are considered a little bit sort of fluffy, in respect, in opposed to sort of ECMO and all the big sort of fancy interventions that we do.
But aren't those interventions kind of depersonalizing the patients? It was always my impression, like I'm standing right in front of an individual, of a human being, but I can't really see the person behind it, because there's this tube, there's that tube, there are ECMO cannulas, there's this, there's that. I can't even see the face because he or she is prone. So I think we tend to think they're fluffy, and we tend to smile at things like yoga and ICU gardens and everything, because we're under the impression that we made it through med school and we made it through this and that and a lot of training and very competitive and it's all very technical. But in the end, I think this mindset is what makes us at risk for burnout, I think, or for situations or states of mind as maybe associated to burnout that may lead to burnout.
What's interesting is that anything that alleviates the patient's or the family's stress also tends to alleviate the clinician's stress. I think we tend to forget that, and we should see the ICU as a system where each person's experience is going to have an impact on the other person's. And so all these interventions that we're talking about that did seem maybe like details before, we understand now that, I think we understood before that they were important for patients and families, but I think we're understanding now that they're also just as important for clinicians.
That's really true.
So we're from 3 different countries here, like we're from France, the UK, and Germany, and we're all talking about ICU, and I think we're all under the same impressions and deal with the same problems, more or less. So this leads to a question from the chat. So why are there still large differences in the prevalence of burnout and in the report rates, and even in the paper about burnout among ESICM members? There were differences between regions and prevalence. So how do you explain this? Or is this explainable?
I think that, well, first of all, it's a good question because we learn from these differences. The first thing is that the pandemic did not affect every country the same way at the same time. So maybe we have captured symptoms in people at different times of the pandemic. And for example, at the time we did the survey, it was much better in France and Italy, but it was starting to be very, very difficult in the UK. And I think that this is one of the reasons for such discrepancies and discrepant prevalence of burnout across countries. So this is the first point. The second point is I think there are cultural bias in the way we report symptoms and we address and complete a questionnaire. And this has been very, very much reported. There is the gender bias, but there is also a cultural bias, making that maybe people in France and Spain don't complete the questionnaire the same way. Maybe there is a kind of I don't know. This is a very well-known bias for questionnaires on mental health symptoms. And the last thing is, my feeling is that the differences that we captured exist inside the same country between different ICUs in Germany, in the UK, or in France, as much as between the UK, Germany, and France. So my feeling is that the differences are also related to how we organize our work in different places. And the differences exist between 2 ICUs in Germany, the UK, or in France, as much as between us. So I would not be so conclusive about these differences. The other thing is that the sample that we analyzed for this survey wasn't really representative. We had 1,000 answers, and these 1,000 answers brought that there were differences across countries. But I'm not sure that every country was represented the same way with a representative sample of every population. So it was a result. Data is data. We are just reporting it and speak about it, and also are able to criticize it. The important thing is learning from each other. I don't know what is so much discrepancy or differences. We learn from our differences. And there is a lot of things in the place where you work that I would love to learn. And there are many things, and you're welcome to Paris, like every person listening to us, to see what we do well and what we can learn from you. So I think that this is the strength of being ESICM members, is that we can circulate from each other. The weekly webinars also teach us a lot of things on how we can learn from each other. This is a major point, rather than saying that there are differences between the UK, Germany, and France. Nancy, I have a question for you about supergroups. Do you think that we said that family members could assist clinicians and help their ICU experience? So we know that clinicians can help the ICU experience for family members, but the other way around, family members could help clinicians to feel better by having another environment. Do you think that there could be support groups from other specialties in the hospital coming and helping ICU people to feel better, to have less burnout and less distress in the ICU? Because this is something that is always discussed. We should have a group of people that we call, the ethical group or the ethical consultants, or people who could come to the ICU and support ICU healthcare providers to be less with distress and less with burnout. Do you think that this is something real, something that we can really?
Well, I have noticed that what clinicians always say is that what they enjoy the most is getting a letter or a call from the patient or from the family to say that they're doing better, that their grandchild was born, or whatever was important to them, and that they really suffered during the pandemic from not having any feedback, because they never actually got to know the patient as a person, because as soon as the patient was a little bit better, he or she had to leave the ICU. So there was no contact. So there wasn't much feedback either from patients, from what I understand anyway, in the ICUs. So I think that if we manage to create more interactions between patients and families post-ICU with the clinicians, it could be a great help, because that feedback is so important, A, for clinicians to understand what they did really well, and B, maybe also to understand what they could do a little bit better, because we can always do better. So that's a first answer. A second answer would be, like, are you talking about Elie, support groups for clinicians, but that would come from other clinicians in the hospital?
I think that, for example, during the COVID-19 pandemic, a lot of other specialists, like surgeons, like gastroenterologists, pulmonary people, were coming to the ICU to help, to inquire, to help for prone positioning, for communicating with family members, for many different things. And I think you said earlier, Nancy, solidarity. And I think that this is really a magic word, on maybe one of the major catchword of this webinar, solidarity.
Yeah, I absolutely agree. And in the interviews that we did, it did, I would say in all the interviews, all the clinicians, whether nurses or doctors, mentioned how impressed they were and surprised that there was so much solidarity within the hospitals and between hospitals too, that they got to know colleagues that they'd never met before, that they discovered professions that they didn't even imagine. And so it really did unite, I would say, clinicians in a hospital, and that they felt like a community. And I think that solidarity is so important, and it was a great help during the pandemic.
Sorry, going back to what you were saying about feedback from patients, which is something which may have you felt lacked during the pandemic, because they were moved on so quickly and it was such a busy time. I think one of the things we were quite lucky here was we had a FaceTime-like software which was called Lifelines, where they signed in and they had discussions with their families, or sometimes we just used FaceTime or whatever, just so the families could see their relatives, and so we could have discussions, so it could give them a feeling of being there. But also, as well as that, we have a virtual follow-up clinic. So even though, I think they're starting now to become face-to-face, that may change again. But, they had virtual clinics, and what happened was we had pictures of the patients as they were then better, how they were getting on, what they were doing. So, and then that was fed back to the sort of whole team. And I think that gives you a really good feeling, a sense of sort of satisfaction that, these people have got better and they're getting on with their lives. So there was some real positive things with the use of virtual medias. So yeah, I think that's helpful, and that's something that's came out. I mean, because before, I think anybody who got a mobile phone out in ITU and filmed or started FaceTiming before that, it was something which, you know, you didn't do, they didn't like it. But now I think now it's become quite an acceptable way of communication between the sort of bedside and the families. So we're not some place that they can't enter, or it's, you know, under such strict control.
And I think even if a patient passed away and we got a letter from the family, it was consoling for us if they said, oh, we're very sad because he or she passed away, but we know that he or she left at good terms and it was okay, and we know you did all you could, and here's a photograph of the funeral, or here's the speech someone held at the funeral. So I think in patients who don't survive their stay at ICU should not be considered as a failure, or we shouldn't just focus on the ones who survived. And we can also, I think, well, this is very personal, but I think you can also find comfort in knowing that a patient who died is not lost.
Yeah.
And if the family is okay with it. Mm-hmm. So I just think this is an important point too.
Absolutely, yeah, definitely.
Laura, as we are going close to the end of the webinar, would you name your burnout study with the next solidarity? I think that's a good idea.
I just think of a catchy name and then email you.
Well, I think we should spend 5 minutes on research, because
definitely.
I understand there is a big interest in our society and with our colleagues, with all ICU physicians together. We have this interest by, you know, working and understanding better how healthcare workers can cope with, you know, all the acute and prolonged stress that can lead to burnout. So if I understand well, if you were doing a study on burnout, you would not only try to capture the appropriate symptoms, but also the differential diagnosis. So you would, by definition, capture, using the Maslach burnout inventory, symptoms of burnout. You would also be forced to measure depression by one of the different tools that applies to healthcare providers. Many different tools exist and are validated and can also be used in different languages, so that could be easy. And then you would also capture information on moral distress and the perception of inappropriate care. So then you would have a prevalence of burnout in healthcare workers, in ICUs, in all our countries. So the interest would be what we can learn from each other. And I would focus on those ICUs and those clinicians with least symptoms of burnout, those who are quite doing well as compared to those who are doing, you know, who have more symptoms of burnout, to know what are the environment, what are the ethical climate, what are the things that are done in these ICUs that allowed those clinicians to have less burnout than others. Is it related to personal traits? Is it related to healthy ICU environment? Or is it related maybe to the nature, the type of patients we have? If you have an ICU full of ECMO, where patients are with ECMO since 30 days, and you know that mortality is going to be very high. So I think that it's very different than if you are doing another type of ICU and intensive care medicine. So is it something that could be of interest for you?
Definitely.
Yes.
And would you, for example, focus on identifying what helps people to not to be well and to not present with symptoms of burnout, and what can make also what we can learn to develop in other ICUs? Maybe think on a very simple intervention that could be done.
Yes, I think so. I would focus on that and then maybe do an intervention and then do another study on this.
And I think I like this kind of studies because it has to be, you know, multidisciplinary. We need to do that with nurses and doctors. We need to have multidisciplinary people in the ICUs. psychologists. Well, I'm very lucky and very proud to work with Nancy, and we're learning from her on a daily basis. But you know, we need to have other sciences coming to us to improve the way we are analyzing our situations. So I think that this kind of works can also lead us to providing, well, of course, a better and healthy ICU environment. But I'm sure that it will translate, and this is maybe part of the work, and you should get some the way you can capture that, some translation into family satisfaction, or maybe least post-ICU syndrome for family members, and maybe better patients' outcomes. I think that we are in a time where people will be sensitive enough to the domain, the research domain, so that you will get a huge addition to your study.
Definitely, and ways. I think there's got to look at ways that you can monitor levels, sort of general levels, and then sort of react accordingly. Maybe I think the pandemic was a good way. That created stress and burnout, and you obviously levels went up, and it's looking at levels and and talking about them and having them in all the sort of different team meetings. It should be something that's on the agendas.
So what would be the catchword of this webinar? Solidarity.
Solidarity.
Yeah. What are we going to take home? What are the messages we are going? Well, let's say, Laura, tomorrow someone in your ICU was just inside, and you would say, well, you should look at the webinar in replay because there was this and this. What would you say? Is it about recognizing the disease, or maybe understanding what is burnout as compared to other symptoms, or maybe understanding that this is something on which we can act and being active to prevent it or to alleviate symptoms? What would you say?
Well, all of those. I would just say it's a webinar on the different aspects, and it's dealing with burnout on multiple levels.
So Trish, what would you say?
I think it's really important to talk about it, to recognize it, to think about teamwork and how it can help prevent it. The team, there's reasons why you sort of try to have good teamwork, and that it helps with your everyday work. It helps the individuals who are part of the team. I think it's about peer support and being there and talking to each other and looking out for each other when they're starting to have that empty burnout feeling. And I think also it's those things which I think there's a slight bit of snobbery, but it's the fluffy things. It's the things that I think there's a great drive in ICU for all things, all the brilliant interventions which we do. But I think also sometimes it's back to basics, because if you can't get the basics right, then why strive for the big things? I mean, it's the basics. I mean, it's happy teams, create happy patients and happy relatives. And then that's the things we should be looking for. And it shouldn't be just lip service. It should be considered a very important and integral part of our working lives. That's what I'd take home.
Nancy, what would you say?
I think, well, it's the first time I've participated in a webinar, and I think it's a very interesting way of, communicating and discussing ideas. So I would say that it's different to when you go to a conference, because you listen to one person and there are one or two questions at the end. So I would say that the interactions between us maybe helped us all understand what we're talking about a little bit better.
Yeah, I really agree. And I think that one of the key messages is that we should not be ashamed of being interested in something like that. It's not less interesting than sepsis or than acute respiratory failure or than positioning for RDS. I think this is part of our job. We need to consider that team building, management, and healthy ICU climate is really important, and as much as other research domains, because this also translates into healthcare providers, patients, and family outcomes, and we should pay attention and give importance to that as much as all the rest. We are in a wall, and I don't think that we can we can care for patients without caring for the carers. And this is one of the major things I think that we should give attention to. So I think that Laura or Trish, you need to give the concluding remark, and then we will be happy to conclude the webinar.
Well, I think it's been a fantastic webinar. We've covered a wide range of subjects, and I think it's a subject that should remain on the table to discuss. And I think all the MDT should be involved. I think they should carry on the fantastic research that Nancy and Elie are doing. I think it makes a great difference to the service that we provide to the patients and to their relatives. I think the end of the pandemic and the period of recovery, we should include burnout, we should include stress management. Even if the pandemics and crises stop, I think it's something that should continue and be part of our working lives. And I'm sure somewhere it's going to say that staff without burnout and without stress has a direct effect on mortality. If we're not stressed, in the same way that with rudeness and incivility has an effect on the outcomes of patients. If we have happy, motivated staff who are in a good place working hard, then it should have a positive effect on the mortality and the well-being of our patients and of their relatives. That's my thoughts.
I will send you my cartoon, Trish, so that because in the cartoon you have all the points that we discussed, and it brings very factual events to healthcare providers. So I hope the cartoon will be translated and given to all the nurses. So any concluding remark before we give back the TV studio to the ESICM?
I have nothing to add.
Okay, so thank you very much. It was a great pleasure, and I think I learned a lot by sharing this webinar, and I hope that we were able to address what people were expecting from the webinar. And of course, we are ready to address any question by email, and we are looking forward to the next study. Maybe it will be called Solidarity. Have a very good evening all, and I look forward to see you in person soon. Bye-bye.
Thank you. Take care. Bye-bye. Bye-bye.